This eMultiple Sclerosis review program is presented by DKB Med Radio.
Pregnancy is protective, and you see a decrease in the MS disease activity and MS damage as the pregnancy goes on. It's really most striking in the third trimester, but you can see ripples of it even earlier in the pregnancy. So you're certainly not going to see MS get worse in your prototypic pregnant relapsing MS individual. And you actually have documented decrease in disease activity by the third trimester. But there's a payback for that.
MS and family planning, the clinician's perspective. Welcome to eMultiple Sclerosis Review. Women newly diagnosed with MS, as well as their clinicians, have many questions about family planning. Should she get pregnant right away, or is it more important to first become stable on a disease-modifying therapy? Can her MS be passed on to her baby? Which DMTs are safest to use during her pregnancy? Does attempting in vitro fertilization increase MS disease activity? And as importantly, what new answers does the latest research provide? To discuss these questions, we're joined today by Dr. Patricia Coyle, professor in the Department of Neurology at the Renaissance School of Medicine at Stony Brook University in Stony Brook, New York, and the founder and director of the Stony Brook Multiple Sclerosis Comprehensive Care Center. For our guest disclosures and additional CME information, please go to our website, emsreview.org, and select the Volume 6, Issue 6 link. I'm Bob Busker, executive producer of DKB Med's e-literature review video programs. Dr. Coyle, thank you for joining us today.
Oh, thank you for inviting me. I'm really looking forward to it.
Our overall learning objective for today's program is to define issues specific to people with MS of childbearing age, such as the safety of various DMTs and the influence of pregnancy on MS activity. Our first focus, and our initial topic of conversation, is to explain why family planning, including pregnancy plans and contraception, should be discussed with all people with MS of childbearing age. So that being said, if you would please, Dr. Coyle, take us to the clinic and start us out with a patient scenario.
Great. Amy is a 28-year-old accountant, and she's recently diagnosed with relapsing MS after a first attack of acute transverse myelitis. Her brain MRI shows 10 macroscopic lesions, 2 of which enhance. She has 3 infratentorial lesions as part of that. She, in addition, has 2 spinal cord lesions, one at C5, one at T2. The T2 lesion enhances and is likely the reason for her transverse myelitis presentation. On exam, she shows a mild paraparesis, a subtle T4 sensory level, and bilaterally upgoing toes. She received 5 days of IV methylprednisolone and resolved within 4 weeks. Amy is married. She's been married for 2 years, and she has no children.
Well, give us your impressions, if you would please, doctor, about her current condition and her anticipated prognosis.
So this is a young woman who's presenting with a recognized clinically isolated syndrome, transverse myelitis hitting her spinal cord. I'm a bit worried about her as the first relapse of MS. First of all, she shows motor disturbances, which is a more severe prognostic feature. She was bilaterally weak. She's showing a mild paraparesis. Secondly, she would be considered to have a heavy brain MRI lesion load with 10 macroscopic lesions in her brain. Thirdly, she has 2 spinal cord lesions and 3 infratentorial lesions. Infratentorial and spinal cord locations of MS macroscopic lesions have been described as poorer prognostic indicators. So this is somebody that I'm a little bit worried about, and I probably want to get her on appropriate disease-modifying therapy quickly. You know, we all say that the presentation of the first attack of relapsing MS is serendipitous because it happens to hit an eloquent area, but we don't actually know that that's true. It may be that something has changed when that individual presents with their MS, and the data is increasing that you want to treat quickly, early, rather than later. So this is somebody that I'm probably going to encourage to go on an adequate disease-modifying therapy.
Talk to us about why family planning is important to discuss with her at this time.
Well, the prototypic MS patient is a young woman of childbearing age, and this is personified here. So honestly, pregnancy and family planning come up as very important issues. Now, if the patient doesn't bring them up, they should be raised by the physician because it is so important and it permeates decision making and may influence the choice of treatment and disease modifying therapy. This is a newly diagnosed young woman who's early in her marriage, who does not have children. So you really want to reach out and have a discussion pretty early on what are her plans, if any, for getting pregnant, for having children, et cetera. You want to bring up that discussion. And I'm sure she has questions. One of the hidden questions that may be lingering there, and often they're afraid to bring it up, is, can I pass my MS on to a child? That can be a very important issue to raise and answer for an MS newly diagnosed individual.
Can multiple sclerosis be passed on genetically? Of course, that's a question many people with MS considering pregnancy are likely to have. There's been a lot of research in this area, and we may be addressing it all in depth in a future issue of eMultipleSclerosis Review. But as a quick summary, what the evidence has shown is that MS is not inherited. Yes, some genes have been identified that may increase the risk of developing MS, but they alone do not explain why or how MS occurs in any particular individual. But let's return to family planning, doctor, because we haven't yet discussed contraception, a key element of family planning. Talk to us, if you would, please, about how you would discuss contraception with this patient.
I think this is very important because I think neurologists that are diagnosing a young female of childbearing age with MS have to discuss contraceptive techniques. You really want pregnancies to be planned in MS, not unplanned, because the patient is likely to be on medications, including disease-modifying therapies. So you don't want accidental pregnancies. And therefore, discussing contraception is a very valid topic. There are different types of contraception. You can have barrier contraception, which is about 70% to 80% effective. You can have hormonal therapy, including combined hormonal therapy, that's about 90% effective. Or you can have long-acting reversible contraception, the so-called LARC. LARC. These are IUDs or rod implants that last 3 to 10 years sometimes and are greater than 99% effective. So you want to know if your young, newly diagnosed MS patient, female of childbearing age, is using contraception. What type are they using? And I think there's a role for the neurologist to really push the very effective contraception treatment, which is LARC. So that should clearly be discussed, I think.
A quick question, doctor. What contraception is this patient currently on?
So it so happens that this particular patient is on a birth control pill, an oral birth control pill using hormonal therapy. And that's reasonable. It's about 90% effective. Maybe she's never heard of LARC, and you want to bring that up. In fact, the 2018 American Academy of Neurology guidelines actually say that we should be counseling on the use of birth control during the period where we're going to be using a disease-modifying therapy, because you want pregnancies in MS to be planned. And the other thing to mention is that the typical pregnancy in your typical relapsing patient, because they make up the bulk of those that get pregnant without any marked disability, that is not in and of itself a high-risk pregnancy. That should not be. That would be confined to a small minority or perhaps progressive MS individuals that have more motor impairment. Your average early relapsing patient with very little in the way of disability, that is not a high-risk pregnancy. So I think that's also important to emphasize.
Another question your patient might have but may not voice. Should she attempt to get pregnant right away, or should she stabilize on a DMT first? What does the evidence say about that?
Well, I think I gave a hint about the value of early treatment. When MS has declared itself, I think the data is accumulating that the earlier treatment is started, the better. There may be a critical window of opportunity that literally may be in terms of a few months, 6 months or so, where you get the best long-term outcome by treating quickly and stopping the cascade of immune-mediated damage that led to the clinical presentation with an attack. So I'm going to favor treating the MS once it's declared itself, making sure that's quiet for at least a year, probably 2 years if I have a more unusual, very active relapsing MS patient, and then talk about our options for getting pregnant when things can be controlled much better. Keep in mind that the data has said that there's a postpartum, after giving birth, risk of increased MS disease activity that's about 3 months long. And the pre-pregnancy attack rate kind of determines that. So you'd like somebody to be attack-free for a fairly significant period of time before they get pregnant.
Disease-modifying therapies. Which ones require a washout period before attempting pregnancy?
This is a critically important issue and is why it's so important to keep up with the literature, including expert consensus, because this is evolving over time. So first of all, I lump all the disease-modifying therapies for MS, and there are a lot, into the immunomodulatory needle injectables from the 1990s, the oral agents that began in 2010, and the monoclonals. So those three groups. Now, we know very well that there have been thousands of human exposures with the immunomodulatory agents from the 1990s. Those are the disease-modifying therapies we've had the longest. And that's glatiramer acetate and the interferon betas. And they are really quite safe, and you do not need a washout. So if you're on one of those needle injectables, immunomodulators, they're not immunosuppressive, you would take it until you discovered that you got pregnant. When we move to the oral agent, there's one agent, the fumarates. Dimethyl fumarate is the parent compound that has a very short half-life. It's less than an hour. The fumarates you need to take twice a day. There's really no animal model data that indicates that the dosing being used in humans, there's any teratogenic effect in any animal model. And the pregnancy data to date with the fumarates doesn't indicate any issue. So by expert consensus, you would not use a washout with the fumarates. You would continue them until the person got pregnant and then stop them. Then we have natalizumab. Natalizumab is a humanized monoclonal antibody. The issue with natalizumab is that a minority can have rebound when that medication is stopped. And there have been devastating pregnancy attacks in people that were on natalizumab and then stopped it because they got pregnant. So you definitely don't want to do a washout with natalizumab. In fact, you might consider using it during part of the pregnancy. Finally, I'm going to mention the very popular anti-CD20s. And I'm talking about the humanized anti-CD20 ocrelizumab and the human anti-CD20 ofatumumab. If you look at their label, they'll tell you there should be basically a 6-month washout, which would mean that you'd never be able to get pregnant on those anti-CD20s. But expert consensus in one of the articles that we discussed made the case for not using a pregnancy washout with those anti-CD20s. It's not a toxic molecule. It's IgG. It's an antibody. Antibody's only going to pass as the placenta develops, which is typically in the mid portion of the second trimester. There's really no animal data of any issues, and there's mounting, combining all of the anti-CD20s, human data that indicates no issues. So you can continue those anti-CD20s until the person gets pregnant and then discontinue it. So those are the ones that I think don't need a pregnancy washout.
Another common patient question, doctor, about the impact of pregnancy and the impact of giving birth on a woman who has MS. What would you tell your patient about that?
We can give her very good counseling. Pregnancy is protective, and you see a decrease in the MS disease activity and MS damage as the pregnancy goes on. It's really most striking in the third trimester, but you can see ripples of it even earlier in the pregnancy. So you're certainly not going to see MS get worse in your prototypic pregnant relapsing MS individual. And you actually have documented decrease in disease activity by the third trimester. But there's a payback for that. With the abrupt termination of the pregnancy and perhaps a change in the multiple hormonal factors that have elevated in levels and suddenly being turned off, there is a consistently recognized approximately 3-month postpartum period where MS individuals will be at increased risk of having MS disease activity. So those are two very important things to counsel about. Now, the good news is that in the typical pregnant MS individual, that's a relapsing individual without any marked disability, there seems to be no negative impact of pregnancy at all. In fact, some trials have suggested a positive benefit long-term in relapsing patients who experience pregnancy versus those that do not. I'll just comment that only a minority of pregnant MS individuals have progressive MS. That's a more severe form of MS with prominent neurodegeneration and smoldering inflammation. And so it's harder to make clear-cut statements about the unusual progressive pregnant MS individual. And we really need to think about registries to try to get larger numbers in that particular clinical phenotype.
Thank you, doctor. Our key learning focus for this part of our discussion is to explain why family planning, including pregnancy plans and contraception, should be discussed with all people with MS of childbearing age. So if you would please, doctor, summarize the most important things you'd want our learners to take away from this part of our discussion.
Well, certainly that MS is not inherited. There are a bunch of risk susceptibility genes, at least 233, but each of them explains just a little bit why MS occurs. Genetics appears to be relatively trumped by environment. MS is not a high-risk pregnancy. All pregnancies ideally should be planned in MS. We have to counsel that MS disease activity decreases during pregnancy, particularly the last trimester, but then has a rebound temporary increase in the first 3 months postpartum. And that's why it's so important to work out ahead of time with your healthcare provider what's going to happen postpartum. Are you going to breastfeed? For how long? Are you going to go back on your disease-modifying therapy, et cetera? These are all things that should be worked out long before the situation comes to that point.
Thank you, doctor. And we'll return with Dr. Patricia Coyle from the Renaissance School of Medicine at Stony Brook University of New York in just a moment. Providing the best care for your patients takes more than identifying the most relevant information. It takes expert opinion and analysis of the data, combined with expert advice about how to most effectively put that information into practice. It takes the Johns Hopkins University School of Medicine e-literature reviews. Top experts in their specialties, selecting the most important peer-reviewed literature, analyzing the information, and explaining what it can mean to clinical practice. E-literature reviews, independent medical education, CME, certified by Johns Hopkins University School of Medicine, and presented without charge by DKB Med. Welcome back to today's eMultipleSclerosis Review program. Our overall learning objective is defining the issues specific to people of childbearing age with MS, such as the safety of various DMTs and the influence of pregnancy on MS activity. We've been speaking with Dr. Patricia Coyle, professor of neurology at the Renaissance School of Medicine at Stony Brook University in New York, and director of the Stony Brook Multiple Sclerosis Comprehensive Care Center, about why family planning, including pregnancy plans and contraception, should be discussed with all people with MS of childbearing age. Let's turn now to our second key learning focus. Describe why assisted reproductive technology should be available to all individuals with MS. So if you would please, Dr. Coyle, take us back to the clinic with another patient scenario.
Well, now we're going to look at Rebecca. She is a 36-year-old woman. She has relapsing MS. It's very well controlled on the humanized anti-CD20 ocrelizumab that's given intravenously twice a year. Now, she's been trying to get pregnant for the last 10 months, but she's failed.
10 months trying, but failing to conceive. What's your initial take on this patient?
Well, this is hinting at an infertility issue. If you look at infertility, it affects maybe 10 to 20% of the population. And there's increasing studies that suggest infertility may be increased in MS, and yet the MS individual may be less likely to go through fertility treatments, which is a conundrum. The major assisted reproductive technology is actually in vitro fertilization. Now, looking at our individual here, she is older than age 35. That's a magic cutoff where fertility markedly decreases. So that raises a concern. She's also been trying to get pregnant for 10 months. Some people would say beyond age 35 or higher, if you have been trying for 6 months and can't get pregnant, you likely have an infertility issue. Now, I am really a big believer in choice. If somebody doesn't want to have children, that's perfectly fine. But if somebody does want to have children, then they should be entitled to all of the techniques that can help that to come to fruition. And that means in vitro fertilization, perhaps assisted reproduction technology. And so that's something that might be encouraged for this particular MS individual to seek out and be assessed for.
The impact of in vitro fertilization on people with MS, what's known about that?
So this is very important, and this is a very important lesson. Originally, over the last several years, there were 5 geographically disparate reports that came out, very small groups, that reported that assisted reproductive technology, in vitro fertilization, if the MS individual failed to get pregnant, it was associated with a 3-month period of increased MS disease activity, harm to the patient. And this was particularly true with gonadotropin-releasing hormone agonists. Now, because this was 5 separate studies, although each was very small, this led to really counseling MS individuals that they were at risk if they went through in vitro fertilization, and perhaps they should completely avoid and have their fertility doctor avoid the use of gonadotropin-releasing hormone agonists. Now, the problem is these were all small studies. Lo and behold, and we quoted one of the articles, we had a French national study that looked nationwide at 2010 to 2015 use of in vitro fertilization by MS individuals, and they had several hundred people in that study, way larger than the initial 5 reports over a couple of years. They did not confirm any increased risk of MS disease activity as measured by needing to admit or treat for a very bad relapse, and they didn't find any association with whether you had a gonadotropin-releasing hormone agonist or antagonist or were using another technique. And then this was confirmed in another pretty large study at 4 academic centers where the exact same thing was found. This now flip-flopped and changed the counseling for us to say, no, it doesn't appear that in vitro fertilization, whether it's successful or not, leads to any increase in disease activity. And it doesn't matter what you use, it's not going to be an impact. The larger studies gave us the more accurate counseling to give our MS individuals.
Is it recommended to keep patients with MS on their DMT while they go through in vitro fertilization?
Absolutely, if possible. The large studies found that continuing on your DMT seemed to be quite protective against any increase in disease activity. So this can be discussed with the fertility doctor, but if there's no reason to stop the DMT, you want to continue it up to the time you're going through the IVS or even during it if your fertility doctor allows. That's helpful.
Which DMT could be considered safe for use during pregnancy?
Well, natalizumab for sure. Natalizumab is typically continued. You can go to an extended dosing every 6 weeks to 8 weeks. You could probably go up to even 34 weeks. But there really have been nasty rebound relapses during pregnancy if you abruptly stop that. So that's one concern. Glutathione acetate and interferon beta, they are not immunosuppressive agents. They have thousands of pregnancy exposures. There's absolutely no issue with it. In particular, glutathione acetate has been used to treat hundreds of pregnant MS women, so they could be maintained. And finally, I want to put a shout out for the anti-CD20, at least ocrelizumab and ofatumumab. One beauty of the anti-CD20s is the infrequent dosing. An anti-CD20 has been used during pregnancy selectively. If you use it in the latter part of pregnancy, you're going to need to check the baby with regard to B cell count, et cetera. But you may really be able to use the infrequent dosing of, let's say, every 6 months earlier in the pregnancy where the IgG antibody is not likely to be passaged through a placenta that is still forming and still get the long-term benefit of suppression of B cells. So those are all possible DMTs that could be considered for use in pregnancy if somebody was quite active or you felt that you needed to treat them.
Let's go to the next step now, doctor. Let's say she becomes pregnant and she delivers a healthy baby. What does she need to know about breastfeeding?
Well, I think it's very clear. The rheumatologists are more prominent in this, but certainly neurologists should know going on a monoclonal antibody, that is not a contraindication to breastfeeding. So you can be on a monoclonal and breastfeed. Very little of the monoclonal gets into the breast milk, and it seems to be chewed up in the gut of the newborn baby. So people might say just don't breastfeed for several hours after a monoclonal infusion, but they are on the table to be used. The same thing with glutathione acetate and interferon beta. They can be used during breastfeeding as well. And probably in MS, you want to use exclusive breastfeeding, meaning less than a bottle of milk a day. That seems to be most protective. At least there's some data suggesting that.
A final question, doctor. When would you suggest this patient restart her disease-modifying therapy?
I'm going to say as soon as possible. So it really depends on, is this a DMT that can be done with breastfeeding or not? How long is the patient going to breastfeed for, et cetera? Keep in mind, an infusion of a monoclonal, you can just delay maybe 4 to 8 hours breast milk feeding, and you should be good to go.
Thank you, doctor. Our key learning focus for this part of our discussion is explaining why assisted reproductive technology should be available to all individuals with MS. What are the key concepts you'd want our learners to take back to their practices?
Well, the first thing is the most recent data indicate there's no documented risk to an MS individual that goes through assisted reproductive technology, in vitro fertilization. Everybody has the right to become pregnant if they wish, in my opinion. There is a concern about an increase in infertility. We certainly don't want MS patients withheld from the right to go through IVS, for example. And you want to move more quickly if you're age 35 or older with MS, and you want to continue your disease-modifying therapy into the assisted reproductive technology IVF techniques.
From the Department of Neurology at the Renaissance School of Medicine at the Stony Brook University in Stony Brook, New York, and the Stony Brook Multiple Sclerosis Comprehensive Care Center, Dr. Patricia Coyle, thank you for sharing your knowledge and expertise with us in today's eMultiple Sclerosis Review program.
I think this was an extremely important topic. It's evolving over time. People need to keep up with the literature. It's so critical to counsel our MS patients appropriately. I hope everybody found it valuable.
For eMultiple Sclerosis Review, I'm Bob Busker.